I do teach a lot of students and new graduates, and I find that during the course of their training, they get told a lot of ways to go about treating lower back pain, but they don't really have a structured thinking about why the person is in pain. And as we know, look, really, there's no single reason. And if anybody had the one way that was great, then we'd all be doing that thing. So I think the huge variety of methods to treat lower back pain is a bit of an indicator on how complex it is. And nobody has a true handle on it. And I'm not suggesting for a second that this is the only way to treat lower backs, but hopefully it gives you some structure and some thinking in a very, very basic way so that you can implement the thinking straight into clinical practice later on today or tomorrow, and that you can also give a viable explanation to patients, which I think is really important in terms of understanding pain. So as we know, I now have an issue with my screen. There we go. As we know, there is a huge burden of lower back pain in society. It's both costly from a financial perspective to workplaces when people can't work, but costly in terms of the individual not being able to participate in life and do the things that they love doing. I think all of us have treated chronic lower back pain, and you discover that it makes for a miserable existence for those people who suffer from lower back pain. Acute lower back pain is equally miserable and can prevent people from participating in life in a meaningful way, even in a short period of time. So there is a lot of pressure on us as clinicians to get the situation under control for our patients as rapidly as possible. We know that through a plethora of information worldwide, and particularly in Western society, that the global burden of this issue is absolutely huge. It's one of the most significant non-life-threatening conditions that faces us. Such to the point, though, that the incidence of lower back pain is so high that we've almost normalized it. I'll often hear doctors sort of say, oh, yes, you're over the age of 40, it's completely normal to get back pain as a result. And I would suggest that pain is the body's way of letting you know that something's amiss. It's not something that should be tolerated. It's actually a flag that something is wrong. And I certainly don't buy the fact that just because you get older, it's okay to have pain. And I often say to my elderly patients, okay, well, if you're 85 and you have toothache, do you go, oh, well, my teeth are 85 years old, I don't need to worry about doing anything because that's just age. And they laugh and say, well, no, of course, I'd go to the dentist if I had a toothache. And you go, yeah, okay, so come to the therapist to try and alleviate your back pain, and let's see if we can work out why you're getting it. So most of what I see is that people speak about the ways to manage back pain, and there's obviously a variety of different treatments to alleviate back pain, but there's not much discussion about the genuine causes of lower back pain, partly because it is so complicated. So some of the things that get thrown around as to why we get back pain, sedentary lifestyle, weak abdominals, poor posture, degenerative disease, or the current flavour of the month is, weak glutes and the biopsychosocial factors that contribute to pain. Now, I think all of these are probably relevant, which is what makes it so difficult to treat. And I think the trick as the clinician is to try and work out, okay, which of these factors are involved and how important are these factors? And you might need to treat, half a dozen things to truly get rid of somebody, particularly if they've got chronic pain. But you might need to be looking at multiple different areas. The research can also be quite misleading or confusing because, we used to think that, oh, it's because of a disc prolapse, and then we fixed the discs and discovered that people still have pain. So, oh, no, it's not disc prolapses. We think that it's weak gluteals, and we strengthen the gluteals, but then we discover that, oh, no, they've still got pain, so it's not weak gluteals. So again, I think it's a highly complicated area, and as a clinician, you need to be aware of multiple different aspects. So it comes back to, well, can we come up with a simple platform that starts us off so that we can create a beginning for sorting through all the different things that might be feeding into lower back pain. Okay, so very quickly and simply, we're going to look at some basic anatomy. Because I believe that fundamentally it comes back to how our body is used in our society, and the forces that are applied to the back that make us move in particular ways, and potentially then overload structures that might lead to pain. So very quickly, as you all know, we have a spine that's made up of, as I say to patients, a hard bit and a squishy bit and a hard bit and a squishy bit in a column, 24 vertebra high. So that column is designed to compress down nicely like a giant spring. And the mass of our body is supported by the increasing size of the vertebra as we go from the cervical level down to the lumbar level. So we are actually beautifully designed to be walking the grassy plains of Africa on 2 legs, contrary to belief that some people say we never should have got up after 4. I think we should have got up from the 4 limbs, but we probably made a mistake by sitting down again. So I think our seated nature is part of our problem fundamentally. Okay, if we look quickly at the anatomy of the facet joints, you'll recall that the facet joints actually guide the motion of the vertebra, such that at different levels of the spine, there are different movements that are allowed to occur based on the facet joint angle. Now, essentially, you can think of the vertebra as kind of rocking and rolling on the intervertebral disc, and the facet joint is the thing that limits the movement in any particular direction. As a bit of a reminder, you'll remember that most rotation occurs in the upper cervical area, so you see 1, 2, with cumulative total through the thoracic spine. And it's important to remember that there's very little rotation that occurs in the lumbar spine. So I'm often at a loss to explain why therapists give sort of rotational lumbar spine exercises where they're essentially trying to twist the pelvis on, you know, lying on your back, and you're twisting your pelvis from side to side to try and get lumbar rotation, when rotation isn't actually a movement that the lumbar spine is designed to absorb. I would suggest that probably what you're getting is a stretching of some of the muscles that have gone to stabilize the lumbar spine to prevent it from doing exactly that, aka to stop you from rotating, given that the lumbar spine is clearly not designed to do it. I do find a lot of therapists forget that the lumbar spine isn't really supposed to rotate, and that its principal function is flexion and extension, with some degree of lateral flexion as well. So our main points to look at today are very simply related to, you know, the laws of physics, and again, very simple physics. So the first one is that gravity is a vertical and compressive force. So as we discussed before, your spine is made up of the hard vertebral disc, hard vertebra, and the squishy intervertebral disc. And that works beautifully as long as it's kept in a relatively vertical alignment. So when the spine is not aligned with the line of gravity, then you're having to make discs and muscles work much harder to support the downward force. Okay, I would argue that in a very flexed spine, you know, this is talking cervical spine as well as lumbar, that you are getting potentially excess overload of force going through the muscles, and the muscles have to then support that force. As we know, muscles that can get fatigued if they don't get a break and a rest, and that this fatigue can potentially cause either pain or failing of the muscle if it's subjected to significant increase in load. Right, so one of the reasons why I think postural aspects of the spinal complaints are relevant is because of this overload of the same structures all the time, particularly the muscles. So in very simple terms, you need to be looking at somebody's alignment against gravity and go, okay, well, are we finding that there is stress and strain that's placed on particular muscles, potentially ligaments as well at end of range, and is that contributing to their pain?
Nat, can I place a question here at this point? I think it's very like important also, and important aspect to bring in, that you're really working and educating your patients in their alignment. So how much focus do you, and maybe that's something that we will talk about later, but how much focus do you put, like in percentage, on really educating the patients to find the body alignment and keeping the spine in a good position? Because from
I
nerval,
actually,
or do you?
yeah, I actually speak a lot about it because I think, you know, there's some recent research by Peter O'Sullivan that talks about it's okay to slump sit, and it's okay to have a slouch posture, and maybe we should be more comfortable bending with a flexed lumbar spine, and that these things actually aren't a problem. Now, to some extent, I agree with that I think that it's, you know, what the research shows is that movement is way more important than correct posture in minimizing certainly neck pain, which is what the most of the research looked at. And I absolutely 100% agree with that. However, we live in a society where people are, for the most part, put into positions where they have to be static. So suddenly, the longer you're still, the more important your alignment against gravity is. Okay, and could you imagine a classroom of children being advised that, oh, no, you only need to be in one posture, you can slump, you can lean, you can do this, that, but you have to change your position every couple of minutes. The classroom would be a complete disaster. So whilst this is a really great example of how what we do in research in the lab environment doesn't actually translate particularly well to the real life environment where we do have people sitting at desks for prolonged periods of time. You know, we do encourage children to sit still, and we probably shouldn't, but that is the reality of our life. So I think educating patients in just basic terms of physics and why their alignment, you know, grossly, I'm not talking, you know, little asymmetries here and there, and we need to take an x-ray, just gross alignment against gravity is important because no different from a fence post. If you put a fence post in straight, it stays up and gravity arguably stabilizes it. You put it in at an angle, you're going to need a guy rope to hold it. Because over time, gravity is going to get hold of it and shove it to the ground. But there's going to be constant tension in that guy rope. So if we're not aligned somewhat against the alignment of gravity well, then these guy ropes, these intrinsic guy ropes that we call muscles, are going to get overloaded. And yes, that absolutely can contribute to pain. So I think later on in the presentation, I'll show you a quick little drawing that I do for patients to explain that.
Wonderful.
So I think for the most part, it's actually a significant part of what I educate them about, but it's not, you know, I really spend 5 minutes on it. It's a small but very significant part. And with the drawing that I do for them, everybody has that aha moment. And I think when you have that moment where your patient goes, oh, I get it, then you've captured them. Then you have given them a reason to do the exercises that you might be giving them. You've given them a reason to change their workstation setup. I think we can run into the habit as therapists of just telling patients what to do. And some of them will be compliant in that. But I think when you give somebody a reason that they really understand as to why they're changing what they're doing, then you get good compliance.
Yeah, good points and interesting points. Let's listen to more of that. Also, a lot of the therapy and like basically therapy happens after our like active session with the patient. So also a lot up to the rest of the time that they are spending outside of the one hour session we have with our patients. So that's a very interesting point on
Absolutely.
different components.
Yeah, and that reflects also in research. I was walking a student through the recent research that showed that stretching doesn't elongate muscle tissue. And I said, well, that's odd, because I had a patient just a couple of weeks ago who wanted to be able to do the splits for dance. And so we gave her a stretching program, and, you know, 7 weeks later, she was fully in the splits. So I said, well, if stretching doesn't work, why can she do the splits now?
Yeah.
When we looked at the research, though, a gaping great hole in it was that they didn't consider what the subjects were doing when they weren't in the lab getting their 30 minutes daily stretching. And to me, that is a huge component, and that's what you're saying, is that we are responsible for what we do in the rooms with patients, but they are responsible for every other minute of the day. So it's important to capture what they are doing that might be contributing to their pain, because if we don't change that, then we're going to go around in circles, and that's what chronic pain really is about. Is, you know, chronic pain only exists because acute pain hasn't been appropriately managed either by the therapist or the patient, usually both. So in terms of wear and tear on discs, obviously a chronic loading of a disc can occur if we're constantly bending forward in the wrong way and not using sort of our legs, and we can get that anterior to posterior pressure that can potentially cause cracking of the disc and herniation of the disc substance, which again we all know may or may not be the cause of somebody's pain. The research would indicate that whilst there are a significant number of people with disc issues that do have pain, MRI studies have shown that there are many, many people wandering around with disc prolapses that don't have any symptoms at all. So again, whilst the research is fabulous to get some insights on, I think one of the confusions with looking at and focusing on this evidence-based practice is that there is a lot of conflict in the research about, well, what does cause back pain? Because the Cochrane Review a number of years ago gave us every anatomical site as a reason that pain did not occur, but could not give us a reason why the pain did occur, which leaves us again floundering for a decent explanation. So hopefully I'll present one today. Okay, if we continue to look at those disc prolapses, what research does indicate is that a lot of them happen, the cracking of the annulus, so the tear of that outer fibrous ring, actually tends to happen from the inside out. So if you consider a rotation of the lumbar area, which we've already identified is not designed to rotate because of the facet joint, because that facet joint is there and quite vertical, you're going to probably force rotation to occur in the disc instead of through the facet region. So in the thoracic spine, it occurs at the facet joint. In the lumbar spine, if you're trying to rotate, you're going to end up rotating through the disc matter. Now, that's going to create torque that's going to go from strongest at the center and radiate outwards. Well, research would indicate that that's where how a lot of the disc prolapses occur, is a fissure that starts on the inside and radiates outwards. So that brings us back to how people move, and if anybody's trying to rotate through the lumbar spine instead of the thoracic spine, then they're going to increase the risk of probably having some discal problem, and potentially also increase the need for muscles to try and support that movement that's not supposed to occur there. So you probably are familiar with this very early research by Nackhamson that actually looked at the intradiscal pressures in various positions. It was subsequently redone in 1999 by Wilkie et al. And it showed a fairly significant correlation between what the findings are here, but suggested that depending on how you sat, the intradiscal pressures might not be as bad. So obviously, if you're leaning back against a backrest, then the weight going through the discs aren't as significant. And certainly a lot of members of our society do lean back against the backrest, but that creates another problem that we'll go into in a second as to why they might have lower back pain. But certainly, quite old and more recent research does indicate that there are very high pressures put through the discs in unsupported slumped sitting. And yet that's where a lot of certainly children will start life off. So straight up, we're kind of going, okay, we're dealing with some forces in that lower back area that need to be supported by muscles and joints and discs. Okay, our next key factor is that force will take the line of least resistance. It's a very simple concept of physics. So if we have a quick look at the anatomy of us, we'll appreciate that there's a large, heavy skull that can't absorb terribly much force. Then you've got a neck sort of waving around in the breeze that's supported by fairly slender muscles. Then you have your thoracic spine, which has ribs coming around it. So those ribs kind of create a scaffolding that is somewhat resistive to motion. You've got your lumbar spine waving around in the breeze again, and then your very strong, hard pelvis. So your line of least resistance is in the cervical and the lumbar region. Now, if you stop and think about the presentation of most of your spine pain patients, I would suggest that the vast majority of them come in complaining either of neck pain or lower back pain. And very few will come in complaining of thoracic pain. The exceptions to that rule are medial scapular pain, which from my experience tends to come from the cervicothoracic junction anyway, or people who have pain at the apex of the thoracic kyphosis. And again, we're going back to physics, that at the apex of a curve is the most force. At the most force, there's going to be the most need for the tissue to support that force. So there'll be a lot of load on the joints and obviously a huge load on the muscles. So you will have thoracic pain patients present with pain at that apex of their thoracic kyphosis. But apart from that, there's not terribly many people who present with thoracic pain compared to the cervical and lumbar pains that we will see. So force takes the line of least resistance. The neck and the lower back are less resistant to force and subject to more injury. Okay, in the lumbar spine, which is what we're looking at today, we obviously have that area supported by the abdominal muscles, and your transversus abdominis in particular, that's like this corset that wraps around to try and stabilize the lumbar spine. Now, Gwen Joel, an Australian physio, did a lot of work on the role of the transversus abdominis and discovered that people who had chronic lower back pain tended to have a weak transversus abdominis. So the whole world started to strengthen the TA. Then more recently, researchers discovered that despite strengthening transversus abdominis, people still had lower back pain. And here's part of the problem, is that if we look at those regional ranges of motion again, and we kind of remember that the thoracic spine is where most rotation occurs, I would challenge you to try this little exercise yourself. If you cross your hands and you flex forward and slump that thoracic spine, see how you go with rotating it, as opposed to sitting up straight, getting an extended thoracic spine and try rotating there. You should find that with a thoracic spine that is in a neutral position, so relatively straight, that you can actually get some fairly decent thoracic rotation. However, if you flex the thoracic spine, it's almost impossible to rotate. And if you think of our sort of stereotypical poor postured patient who's been slumped over a desk for hours on end, who started that way from the age of 5 when they first went to school, and they got sat down for 5 days a week for 7 hours a day for the next 13 years of their life, the vast majority of patients I see with lower back pain have very, very stiff thoracic spines, and indeed have very limited thoracic spines. So part of what I suggest is that the movement that should happen in the thoracic spine, aka extension and rotation, is actually being shunted to the cervical and lumbar regions, which is why those regions wear out and which is why those regions are painful. We know from other joints that, say, for example, if you have chronic pain in the ankle and you've had lots of damage to the ankle, then a surgeon might suggest that the only way to alleviate your chronic pain is to fuse the ankle, because we know that joints that are fused tend not to hurt. So I would suggest that the thoracic spine is rarely a site for pain, because in many patients it doesn't move enough to hurt. and that the movement that should occur there being shunted to either the neck or the lumbar spine is a reason why we can get much more pain in those regions, and anatomically those regions are more vulnerable just by their makeup. Okay, so our next key factor is that mechanical wear and tear will occur in areas that move and absorb force. So I'll often say to patients, if you put a car in a vacuum sealed garage for 50 years, nothing wears out. There's no rust, there's no wear and tear of anything. However, if you move a car, you will find that the areas that need to be replaced, aka the tires, are the things that actually have the most force absorption. They have friction on the road surface. You have all sorts of mechanical parts in a car engine, and it's the moving bits that tend to need replacement with the mechanic, not the body of the vehicle, which, unless you run a bus into it, tends to remain relatively well intact. So if we think of how that relates to our lower back pain patient, and we often end up saying, oh yes, you know, you've got inflammation of the back, or inflammation of the facet joint, or inflammation of some structure as a result of load being placed through that structure. Now, inflammation tends to get a bad rap in our society because, you know, we tend to say, oh yes, you know, you've got inflammation, we need to give you an anti-inflammatory, that's why you're getting pain. However, we have to remember that inflammation is actually a necessary and valuable part of tissue healing. So if our patient is getting stuck in the inflammatory phase of tissue healing and not moving forwards to the proliferation phase, it's arguably possibly because they are continuing to cause cellular damage or the need to repair or replace cells at the same time as they are in that repair phase. So they never actually get through the inflammatory phase and progress. So we have to look at, okay, well, why are they continuing to cause damage at a cellular level, such that for every cell that's repaired, we are damaging another cell, so we never actually get anywhere. Okay, cellular destruction really will come because of load. And again, a law of physics will be, if the force is great enough, if the force is greater than what the material can support, then you're going to get damage to that material. So when we're talking in the body, we're talking that the stress or the load, aka the movement load, the movement force, if it's greater than the body's capacity to absorb it appropriately, then you're going to get some failure of the cells and potentially structural damage that occurs. We have to remember things like, you know, the body will adapt to force to some point. So Wolff's law, if you apply a force constantly to the bone, you'll get an adaptation and a thickening of the bone, such that it can better absorb the force. When we're talking about muscle strength, if we have a weak muscle and we apply a load to it, as long as the load is not too great, then the body will adapt and our muscles become stronger. However, if we lift a weight that's far too heavy and we overshoot that threshold that causes adaptation, we actually cause damage. Okay, so I think that what we have to look at is how much load are we placing through the back? Are the structures able to deal with that load? Are they adapting to that load, or are they failing because the load is fundamentally too great to them? And that comes back again to your posture and the way that you move. Just want to digress quickly to what I call the scan scam. And sorts of things that we find if we do radiology of the lumbar spine, if we're kind of going, okay, well, we think that there's a problem there. What is it? Like, what structure is actually being overloaded? Can we get a scan to sort of prove that there is structural damage? And that might be the reason why our patient gets pain. So the first thing is that one of the common phrases that certainly happens here with radiology reports in Australia is that they'll say that it's age-related degenerative change. The implication being it's age-related, it's completely normal for somebody of that age to have those sorts of changes on X-ray. Now, couple of things that I find it fascinating that if it's age related, my brain goes, well, why are not all the vertebra or the facet joints showing the same sorts of changes? Because they're all the same age. You know, a 75-year-old T2, a 75-year-old T12, a 75-year-old L5. They're all the same age. But if I'm looking at a scan, I'm classically seeing that there's more significant changes in, you know, the L5 S1 region or the L4-5 region, which interestingly are also the two most common areas for disc prolapse. Many gurus now are trying to normalize these degenerative changes and say, oh, we shouldn't get too hung up about what we see in scans. To some extent, I agree. And we're now popularly referring to those age-related degenerative changes that we see on x-rays as just like wrinkles. And I go, yes, they are. They're just like wrinkles. So why do wrinkles occur? Well, wrinkles occur due to the same cells of the face essentially being challenged by our intrinsic sort of habits of facial expressions. So people tend to smile the same way, you know, smokers will smoke the same way and get wrinkles around the mouth. So I would argue that wrinkles occur because there is cellular load constantly being applied, and as we age, our capacity to repair and replace those cells that have been damaged or destroyed due to that load gets less and less. And so as we age, we get wrinkles. Well, how does that relate? Well, here's a fascinating thing that if you have Botox on a face, you can get rid of the wrinkles. Now, somebody can get older and older and older and not have any wrinkles because we've used Botox to ensure that there is no load continually placed on those cells. So it's not age related at all. It's actually force related. And it's force over time that correlates with age. And I would argue the same thing happens with what we see in scans for, say, lower backs. That yes, it's often L4-5 or L5-S1 that shows those degenerative changes. So maybe it's because over time, those same levels of the spine are copying the same amount of load and they're starting to wear out. So our scans can give us information about what's going on from a movement perspective. And instead of looking at the scan and saying, oh, there's your problem, there's your disc disease, there's your degenerative change, to me, those scans reinforce that the person is moving poorly against gravity. They're overloading a significant to a significant extent, a single portion of their spine, and the scan changes that we see are confirming that. They're not the cause of their pain, they're actually a symptom of the cause, which is actually an overload from movement habit. Okay, the same would apply to your wear and tear, your facet joint arthritis, that those areas that undergo the most force are going to wear out the fastest. If it's age related, then they should all be wearing out at much the same age stage. If it's activity related, then it makes sense that those that absorb more force with activity are going to wear out faster. When we look at degenerative disc disease, another phrase that pops up in radiology reports, to me, if it's a disease state, it should be arbitrarily throughout the whole spine, or every single disc should suffer the same issue, because diseases tend to attack specific cells or specific tissues in a specific way. Okay, again, we tend to find that the disc disease happens at that L4-5, L5-S1 region. So it's like, okay, well, it fascinates me that why isn't it occurring at L1 too? It makes sense that if discs are shock absorbers, which they are, or shock distributors, or movement force distributors, if one of them fails, then it makes sense that it's undergone more force than others. And so you go, all right, well, if that level has failed, then it means that that one level's absorbed too much force, then other levels around it haven't absorbed their fair share. So from a treatment perspective, I won't look at the level that's failed. I'll look at the other levels around it and make sure that they're moving correctly, that we're maybe getting the hips absorbing flexion force better through the muscles, that we're looking higher up into the thoracic area and making sure that it's moving properly, so that we can spread the burden of force throughout the spine and into the lower limbs, rather than having it all centered at one particular area. Another thing to consider with that is if we have spinal surgery, it's quite common after a fusion surgery for surgeons to actually warn their patients that they're at high risk of requiring surgery again in the future, because they might develop what's called a transition lesion. Now, these surgeons acknowledge that because they've fused one level, that the force that would otherwise occur and be absorbed at that level is now shunted to an adjacent level, putting more load through that adjacent level, and therefore subjecting that adjacent level to a higher force load and risk of damage, thus requiring fusion surgery in the future. So I go, okay, if they understand that happens after surgery, why is it so difficult to understand that that was actually the original reason for surgery to begin with? That one level was copying too much load, too much force, it failed, and that's why it needed surgery and fusion to begin with. And that gives us a bit more of a I guess, a nice thinking in terms of, well, when I find my patient with lower back pain, can I look, is there part of their back that is absorbing way more force than another part? And my treatment approach, therefore, is to protect that area and get the other bits that maybe aren't working so hard to do their fair share of movement force absorption. Okay, the final very simple factor is pulleys cause levers to move. Now, most of the time when patients come in to see us, they will say, it hurts to move. Well, bones are inert levers, muscles are pulleys that allow movement to occur. So for the most part, in general terms, if somebody's complaining of pain with movement, they're complaining of pain related to muscles. Bones are levers, muscles make them move. Okay, a bone can't move by itself. It needs a muscle to act on it. So when we're looking at range of motion and we're seeing that a patient can't bend forward or can't bend backwards, it can't really be stiffness of the joint per se, if we're talking the joint being the articulation between two bony planes. It has to be related to muscle activity. So that makes it really easy from a treatment perspective that for a lot of patients, all we have to do is alleviate the appropriate muscle spasm and we will get rid of their pain. Coming back to what we were talking of before with regards to posture, this is a very quick, the 5-minute discussion I have with patients so that they truly understand what their alignment against gravity means, is what I call this posture perfect concept. I'm not sure, I'm yet to do a PhD on this, and I will do one day. But if you look at the spine, it's, as you all know, it's made up of 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. The cervical and lumbar areas go into a lordotic curve of about the same degree of 10 to 20 degrees of each. And so I'm arbitrarily calling that a positive curve. If you look at the thoracic spine, it's about a 20 to 40 degree curve in the opposite direction, or a negative. Now, if you add 7 and 5 positive lordotic vertebrae together, you get 12. If you add to that the negative kyphotic vertebra of 12, you arguably get 0. So my PhD will be on whether or not the spine curves and the heights of each of those areas actually enables, if the posture is in the correct alignment and those curves are equal and opposite, that you actually come out as a 0 straight line in line with gravity. That being the case, the force, the compressive force from the ground up, so the ground reaction force, and the mass of the head, the trunk, the torso downwards, so your compressive forces are going to be shunted through the spring of the spine, which is essentially functioning as a straight line. I hope that made sense, but PhD to come. So if we move on to, therefore, well, how do we treat these patients? So classically, patients will either come in with a flexion problem or an extension problem. And whilst I acknowledge that there are lots and lots of different ways that you can to treat these issues, I tend to find that there's a couple of really simple ones if we divide them into a flexion problem or an extension problem. And case in point is I was looking after Guns N' Roses a number of years ago, and I was given 45 minutes to treat a patient who had terrible lower back pain. They were a band member, and I was advised that if I couldn't fix them in 45 minutes, that the show would be cancelled, no pressure. So there are currently about 80,000 people wandering in through the front gates to listen to this band, and I'm being told if I can't make it happen, then the whole thing will be cancelled. So I looked at this patient and I went, okay, whilst there are all sorts of exercises that can be done, and whilst they have weaknesses, and whilst they have stress, and whilst they have lifestyle and biopsychosocial issues, I can't address any of those in 45 minutes that's going to make a difference to this patient who can't stand up properly. So I call them a flexion problem. Now, your flexion problems are classically those that get worse with sitting. They don't like to bend forward, they don't like to lift, and they struggle with forward bending. So I look at them and think, okay, they are stuck in flexion, as in they don't have any additional flexion to offer. They're already at their end of capacity to flex. Now, the important thing with regards to treatment here is to remember that we need to get them to flex from somewhere else other than their lumbar spine. If they're over flexing their lumbar spine, where else are they not flexing from? Where can I shunt the movement to? Where can I shunt that load to rather than their lumbar spine? So you have to recall that flexion is a combination of lumbar flexion and hip flexion. And often I'll see these patients that come in that are stuck in flexion, can't flex further forward. They don't like to sit. They'd rather be upright and walking than sitting down. They classically will have really, really overactive gluteal muscles. So the hip joint is no longer contributing to their forward flexion capacity. And this is where I use the lymphatouch. So I'll get the patient in side lying with their hips flexed all the way up to mimic sitting, to put the gluteals onto stretch. And I will simply lymphatouch the whole of the back part of the gluteal muscles. Okay, sometimes I'll also get in and release their L5S1 or their SIJ with a little bit of just classic mobilizations. But getting better movement through the posterior hip region with the lymphatouch actually enables the hips to contribute to forward flexion, takes the load off the lumbar spine and makes them considerably more comfortable. Okay, I'll often also look at the lymphatouch onto the hamstrings area so that they have that elongation through the whole posterior chain and can comfortably flex forward. Occasionally, I'll find that I need to also give them a hip flexor stretch because paradoxically, the hip flexor can actually become an inhibitor to forward bending if the axis of rotation is shunted. That's a discussion for another day in biomechanics. So my flexion problem is those patients who are very, very sore whilst sitting. I work through the gluteal muscles, as you can see there, with the hips fully flexed. So the patient's inside lying, I forgot to mention that. Work all the way through from the top of the iliac crest to the ischial tuberosity area with the lymphatouch to release those very, very tight muscles. Often I'll find that the gluteals are overactive because the person has pronating feet and that the gluteal muscles are trying to externally rotate to rotate the femur to also then externally rotate the foot to pick up the arch of the foot. As we know, we need to have that longitudinal arch to translate the information from the calf muscle through the foot. And if somebody is really pronating, then they'll tend to lose that arch and have a collapsing foot, which is much harder for the lower limb chain muscles to be working. Okay, so
can I not ask a question in between? Like we very often discuss about the precise pressure levels and different techniques are quite individual, and we really need to see what area is most problematic and so on. But do you have a regular like pattern that you use in your patients? Like if we would take this this type of like lower back problem as an example, like how do you start off with? Do you use certain techniques and pressure values? How do you approach like specifically for the device?
Yeah, a great question. And you're quite right. It's very individual. So often, like, because we put like a friction-free cream onto the skin surface to begin with, I'll be palpating the muscle tissue to feel how tense it is, and that will give me a bit of a guide as to, do I need to start off gently with the lymphatouch? Some patients can be very, very sensitive across that gluteal region, particularly because I put them in full flexion, which is quite a provocative position. But I'm trying to mimic the sitting that they can't do. And I might start off, probably the most irritated patient, I'll start at about 50 millimeters of mercury. Yeah. But for the vast majority of patients, I do tend to just crank it up to 250 and away you go. I mean, yeah. To me, it's one of the beauties of the lymphatouch is if I try and do a massage type technique through the gluteals, those cluneal nerves particularly seem to be really irritated and sensitive. So it can be like massaging with a handful of razor blades, or I often say to patients, does that feel like you're getting a massage with Edward Scissorhands or Wolverine, that they feel that really sharp sort of searing pain. Whereas when I use the lymphatouch, they find it quite pleasant. It's just a lovely way to be able to get the same tissue release that I would otherwise do with sort of manual massage without it hurting the patients. And obviously it's so much easier on my hands if I can use a device that I just gently glide across the patient's surface rather than actually getting in and doing that tissue mobilization myself. Yeah. Frustrating also, answer.
yeah, exactly. Someone's also typing in a question like, do you use vibration as part of the, like from setting point of view? Do you use the vibration settings?
Yes, I sometimes do use the vibration, but I do feel for these lower back pain when they're really stuck and really uncomfortable in that seated position, that really just the pressure, the intermittent pressure, and it's always intermittent. I through the gluteals, I don't tend to use a constant pressure. I'll just use the intermittent pressure up through the erector spinae, which we'll look at later. Sometimes I'll put it on constant and move it up and down, but I tend not to need to put it on vibration. And I think, the patients seem to just like the feeling of just the suction up and down. Some patients find that vibration, I think, makes them kind of a bit like, oh, what's going on? Yeah. It's a pleasant feeling. But I haven't found that it necessarily makes a difference one way or another, but then I'm not particularly scientific because when I put it on, I don't switch it and change it to on or off and see whether it's better for the patient. So I guess I can't really answer that question effectively, but yeah, I tend to do the intermittent setting and crank it up to a higher level of pressure as tolerated by the patient.
I know this is also individual, but like time wise, on average, how much would you say that you use like the device assisted and lymphatouch treatment?
Again, you're quite right. It's very individual. It's outcome driven. So I find that there are some patients that it's like their bodies just lap this treatment up, that the manual therapy that I used to do with the press down, and I guess I refer to it as a positive pressure. I've often found that that's really painful, and yet when you do the same thing in the opposite direction with the negative pressure, it just doesn't hurt. And it only takes, I'd say probably 3 to 5 minutes to get a nice release that's mostly pain-free. Now with the flexion problem like this, I'll treat probably both sides. So I'll have the patient lie on one side, then lie on the other side, so that I get the gluteals released on both sides. But nearly always there's one side that is more symptomatic. That will be the side that I tend to concentrate on. That tends to be the side that has the most soft tissue spasm. So I'll probably spend 5 or 6 minutes doing the lymphatouch on the one that's the most problematic. But again, you know, it's a pretty quick treatment to get a really great, painless, effective result.
Thanks. I think we have so many interesting things to discuss, so we can continue with your presentation. And we also had a question here in between, like, do you have any sample videos? We had some technical issues with sharing some of the videos, but we will link the treatment techniques for you in a separate video, and you can also find educational videos on lymphatouch.com under videos, where you can see the techniques that are used also for release. So please find more videos there. But Nat, please go ahead. We are excited to hear more.
Thank you. And yes, sorry about the technical issues. I don't go well, as you know, Tina, with technical things, which is also why it surprises me that I can use this device without it failing on me. But in a nutshell, it's you know, for those people who are going, oh, what does it look like to do lymphatouch on the back of the gluteals? You got your patient inside lying with hips and knees bent to 90 degrees, and you're literally just working across the tissue like you would use a scanner, really, but you're just using it with the lymphatouch. There's not a lot of complexity to it, which again is one of the reasons why I love it and use it. And certainly it's a place that I start my students and my new graduates who maybe don't have the same acuity of feel that I've developed over 30 years of clinical practice. So they can still get a fabulous outcome with a patient, even though they don't necessarily feel where exactly they need to be. When they scan the whole thing with the lymphatouch, somewhere in there is something that's going to be effective. So it's kind of a bit of a cheat's way of getting a great outcome before they can get experience behind them. Okay, so the next classification is your extension problem. So this is those patients who are kind of stuck in flexion, in that they can't stand up, that they have given all that they can give in terms of extension in the lumbar spine. So typically these are patients who say, I don't like standing, I don't like walking, remembering that when you take a step forward, you have to have an increase in extension of the lumbar spine to be able to step forward. So somebody who is fully extended at the lumbar spine and what I call stuck in extension, they have nowhere else to extend from in the lumbar spine, and they're kind of at the end of their capacity to extend. So they're going into pain. All right, these patients will describe that they have pain when rising from sitting. So they'll tend to be comfortable while sitting, and that's their position of preference. But then as they go to get up, they might be like those patients that want to climb up the wall or they'll put their hands like this chap on their lower back and sort of push themselves up. They really struggle to extend. If you have a look at an objective measure, they won't be able to extend back very far, and most significant is that they have virtually no thoracic extension. So my hypothesis here is really that because they are overextending in the lumbar spine, we have to shunt the force to somewhere else. So we principally focus treatment on improving thoracic extension. So what I'll do there is put the lymphatouch through the erector spinae in the thoracic spine, and you know, release through that, the entirety of the thoracic spine, both sides, but again, concentrating on one side that you might have palpated as being more in spasm. And usually that correlates with the side of lower back pain as well. And then, I might do some mobilizations, again, some classic mobilizations, joint mobilizations of the thoracic spine as well. But most of the time I find that when I release the erector spinae in the thoracic spine and give them somewhere else to extend from apart from their lumbar spine, that they're much more comfortable. I'll also take the lymphatouch down over the sacral region. And again, those of you who've been trained in the Maitland approach that it's all about joint mobilizations, the joints stop at L5-S1. So what happens below there? Well, you've got the insertion of the erector spinae into the sacrum. And if you palpate with your fingers through that area, very close into the spinous processes, you'll discover that there's often a thickening and a tenderness to the insertion of the erector spinae into that sacral region that responds beautifully well to the lymphatouch, just picking it up. Again, that press down forward, that positive pressure can be quite painful, but the lymphatouch picking it up is actually quite a nice sensation. And releasing that tension through the sacrum itself, as all of that soft tissue inserts into the base of the sacrum there, can help improve your mobilization of your L5-S1 segment. Again, getting better extension through the thoracic spine, offloading the lumbar spine gives you more comfort in the person standing up. Okay, these are the people that if they're having difficulty standing up and walking, I will never treat them in prone because if you think about getting off a bed, you have to actually extend backwards to push up off the bed surface. So we're only treating these patients in side lying. So again, left and right side lying, working your way through the thoracic erector spinae, adding in some mobilizations of the thoracic erector spinae and mobilizations of L5-S1 after you've also worked through the sacrum with your lymphatouch, just to loosen everything off and give you the capacity to move somewhere other than your lower back. Okay, and again, apologies for the fact that we don't have a video, but it just shows you that gliding up and down the full extent of the anatomy of the erector spinae is the way I address those sorts of things.
Yeah, and we will share the videos for you later on, and you can find them on lymphatouch.com under videos, where you can find different treatment techniques and as Nat is describing the slidings and lift and pull techniques, you will find those on our website. Thank you, Nat. I think it was a wonderful, very informative presentation with good examples, easily understood, and really enthusiastic approach you have to your patients and treating lower back. I think we could speak for many more hours about the topic. It really covers a lot. So, but at this point, I would like to make a poll, if that's fine. And please feel free to add and type in questions if you have more questions into the chat functions, and we can take care of discussing some of the questions before we end the session. But let's see if we get the poll here active. You should probably be seeing the poll right now. So we have 4 questions here. It's very exciting if you can participate in answering the poll. So we have one question on, did you enjoy the expert session? And the next one in, did the webinar content provide you more clinical insights in lymphatouch applications? Are you already using lymphatouch? And do you work with lower back patients? So I will give you a bit more time to add your questions. So this will also help us understand what you want to hear about in our next expert session. So please type in your questions here. And also, if you have some open questions to Natalie, I think it's an excellent time now to type in the last questions to discuss. How is it, Natalie, with your patients, like when you first started exploring lymphatouch, what did you think about the product? Did you have any expectations on what type of results you would achieve with help of like bringing in technology for this specific patient group? Or I mean, you've been already working with it for so long, so maybe it's a tricky question, but
No,
what did you...
I remember very clearly.
Yeah.
So I traveled the world with my head in my hands, and so I you know, when I trained, my exposure to, I guess, technology and electrotherapy in particular was, I didn't really feel like it did anything. So I wasn't really that enamored with incorporating it into my practice. And you know, I'm familiar with Chinese cupping, and I've done a little bit of that, so I'm a bit familiar with negative pressure. But some people obviously don't like the bruising that is part of that Eastern philosophy. And I didn't like the fact that I couldn't control it. Like, it was just how many clicks on the gun gave me the suction pressure. And, you know, there is a scientist trapped in me there. So I wanted to know, well, how do I work out consistency? How can I ensure that I'm getting the same pressure, and does the pressure matter for each patient? So I'll be honest, when I was exposed to the lymphatouch to begin with, I kind of went, yeah, doesn't really look like it'll do anything. And then I had to play with it, and I tried it on a few patients. And my rule is always, if it can't do something as well or better than my hands can do, then I'm not interested. So what I would do is to feel the tissue and then put the lymphatouch on it and then feel it again. And I found that, oh, well, it's done pretty much exactly the same thing as my hands will do. I mean, sometimes I still have to do some fine tuning with my thumbs, but for the most part, it does exactly what my hands would do. My patient's not screaming, which normally would be what they do if I was doing a positive pressure with my hands. The intermittent suction meant that they didn't get the bruising that you will get with, you know, your Chinese cupping and those negative pressure alternatives. And I love the fact that I can document exactly what pressure that I use, because, as we said before, it is a bit dependent on the patient's you know, the amount of spasm that they have, you know, how tenacious that spasm is, and just their comfort level with the spasm being sort of pulled out. The pressure will change according to that, but I can change it in a second, and I can document what the change is, and I'll look back and go, okay, well, they were only able to tolerate 50 millimeters of mercury last time. Now it's all the way up at 250, and they're saying, oh, that feels great. So to me, that is just another reinforcement that the tissue has actually improved. So I think I had very low expectations, and it's honestly my favorite device. I travel with it all over the world. I can put it in my handbag. It's great. And I think it's bought me a few extra years with my hands, because I'm not destroying my hands as much.
Yeah, thanks for the feedback. Let's see what we have, what results we have from the poll. Can you see the results as well, or is it just for my view? Maybe
I can't see it. No,
you can't see it. Okay, so